Welcome to part 2 of our on-call CT chest recap. In this talk, we'll discuss spine and chest trauma. Be sure to check out part 1 on chest and vascular if you haven't already. Let's begin. First off, are cervical spine injuries. Plain CT C-spine is the standard protocol. Mechanism is usually high energy, though in the elderly, a low-energy fall can still cause considerable damage. The main complications to watch for are cord or brainstem injury at the cervicomedullary junction and vertebral artery injury when the foramen transversarium is involved. That's your trigger for a CTA. Here's the recap table of these injuries. Let's go over the key differences. The craniocervical injury is really a ligamentous distraction rather than a fracture, and it's always highly unstable, the one people undercall. Jefferson is your axial load burst, and the trick is the lateral mass overhang, more than about 7 millimeters, and the transverse ligament is torn. The odontoid fracture lives in the transverse plane, so it's easy to miss on axial images alone. Always check your reformats. And the hangman is a hyperextension injury, bilateral C2 pars fractures, where the wide canal means the cord is often spared. On your report, name the injury and its type, and grade the stability. Flag the vertebral arteries and the cord, with MRI for the ligamentous injury that CT can't fully show. Next, facet and ligamentous injury. The mechanism is flexion distraction, or a rotational force, with spinal pain and radicular signs if the foramen is compromised. On CT, you're looking for facet joint widening, perched or locked facets, and the famous reverse hamburger sign. The main complications are an unstable distractive injury and cord or root injury from malalignment. And because CT undercalls the ligaments, you need MRI for the posterior ligamentous complex. The differential is chronic degenerative malalignment, a spondylolisthesis with facet arthrosis and no swelling, or a vertebral body fracture. These are often unstable, so report the facet position and alignment, and get an MRI to assess the ligaments and cord before the spine's cleared. That brings us to vertebral body fractures. There are different mechanisms for different fractures, as we'll see next. The main complications are cord, conus, or cauda equina injury from retropulsion, and instability with any 3-column injury. These fractures can be non-contiguous, so be sure to image the whole spine. Here's the recap table. Remember, these are all unstable fractures. Burst is an axial load injury, so check the middle column and the retropulsion. Flexion teardrop has that classic antero-inferior fragment and 3-column disruption. Chance is a lap belt flexion distraction, horizontal through the posterior elements, and the one that flags bowel injury. And fracture dislocation has translation on the sagittal, the most unstable of the lot. The main differential is a compression fracture, which, in contrast, is stable and involves only the anterior wedge. On your report, grade by columns and canal compromise. These will usually need urgent spinal input. Now onto chest trauma. A plain CT chest is usually all you need here. The mechanism is blunt or penetrating, with symptoms of respiratory compromise. The main complications are the ones that kill. A tension pneumothorax with mediastinal shift, needing immediate decompression. A large or ongoing haemothorax, and ventilatory failure from a flail segment or extensive contusion. Here's the recap table, and the differences worth mentioning. On a supine scan, the pneumothorax collects anteriorly, non-dependent, so look for the deep sulcus sign, and it can enlarge fast under ventilation, tipping into tension. The haemothorax is the opposite, dependent and posterior, over about 35 Hounsfield units. Flail chest is when 3 or more ribs are each broken in 2 places, giving paradoxical motion. And on the lung, contusion is ground glass with a spared subpleural rim that clears in days, whereas a laceration is a cavity that persists. On your report, describe each component, then flag the emergencies. Your recommendations will vary depending on the type of chest trauma and its complications. Next is traumatic aortic injury. On an ECG-gated CT angiogram of the thorax, the finding is a subtle intimal flap or irregularity at the isthmus, with periaortic or mediastinal hematoma, and usually an abnormal aortic contour. The mechanism is rapid deceleration from a high-speed RTA, or fall, shearing the aorta at the fixed isthmus. The main complications are free rupture, usually fatal at the scene, or a contained pseudoaneurysm needing urgent repair. The differentials are a ductus diverticulum and a motion or flow artifact that mimics a flap, which gating or a repeat scan can clarify. This is one to escalate straight away. A deceleration injury at the isthmus with mediastinal hematoma needs immediate cardiothoracic or vascular referral, usually for endovascular repair. We then have tracheobronchial injury. On a thin CT on lung windows, you're looking for an airway wall defect. A specific finding is the fallen lung sign. The collapsed lung falls dependently, away from the hilum, when the bronchus is transected. The context is a deceleration or crush injury, and the giveaway is a persistent air leak despite a functioning chest drain. The main complications are a tension pneumothorax from the ongoing air leak and airway compromise threatening ventilation. The differential includes esophageal injury, so if in doubt, oral contrast can help spot a leak. A persistent air leak or fallen lung sign needs bronchoscopy and surgical repair, so get thoracics involved. Now to diaphragmatic rupture. On a CT of the chest and abdomen in the portal venous phase, you'll see diaphragmatic discontinuity and intrathoracic herniation. Specific signs are the dependent viscera sign, where herniated viscera abut the posterior ribs, and the collar sign, which is a waist-like constriction of the herniated stomach or bowel. These can present months later after the initial trauma. The main complications are strangulation or obstruction of herniated bowel and a contralateral injury that's easily missed on the right because the liver plugs the defect. Don't mistake this for a diaphragmatic eventration, where the diaphragm is intact but elevated, with no discontinuity. A traumatic rupture needs surgical repair, so flag the herniated viscera and any obstruction or strangulation. Coming to the penetrating wound and soft tissue injury, protocol this with a CT angiography in the arterial phase. Look for a retained foreign body or vascular injury along the tract, as well as a possible organ injury in the path. The main complications are exsanguinating hemorrhage with active extravasation from a tract vessel and hollow viscous perforation contaminating the peritoneum. For the differential, be careful to distinguish true tract gas from artifact. Map the trajectory, flag any vascular or visceral injury, and remember, penetrating cavity injury usually needs surgical exploration. And finally, we have acute limb arterial occlusion. On a CT angiogram runoff, arterial phase from the aorta to the feet, you'll see abrupt cutoff with an intraluminal filling defect. Once you spot the occlusion, assess the runoff to the rest of the limb. These can sometimes be traumatic, on top of the usual embolic or thrombotic causes. The main complications are a threatened or non-viable limb and compartment syndrome. The main differential is dissection or external compression rather than a primary occlusion. An acutely threatened limb is a surgical emergency for embolectomy, thrombolysis, or bypass, so report the occlusion level, the likely etiology, and the runoff. And that wraps up our recap. We've covered spine, chest, and vascular trauma, along with the key cardiovascular emergencies. Thanks for listening.